Hello, welcome to this presentation on approaches to implementing person-centered care for people living with HIV in no-resource settings. I'm Dr. Kanyike Andrew Marvin, and I'll be making this presentation alongside colleagues Janda Mwamba and Claire King. The presentation provides guidance for healthcare providers based on evidence drawn from published literature and case studies where person-centered care has been employed. There is no doubt that person-centered care is important for quality improvement and strategic plans to deliver good quality health services. Evidence shows that person-centered care improves clinical outcomes and the experience of clients and providers. Person-centered care is important in HIV treatment services where we have very high expectations on clients to engage with both the HIV services and their antiretroviral therapy over a lifetime of changing circumstances and different pressures. Person-centered care is important to make sure that people have the support they need to stay in care and take their treatment consistently. However, there is still a gap between the theory and principles of person-centered care on one hand and implementing these principles in practice on the other. This presentation will explore ways for healthcare providers and health facilities to implement and integrate person-centered care into services they offer in a practical way. We will focus on HIV treatment services and how person-centered care has been implemented in delivering antiretroviral therapy. We won't cover prevention interventions or testing services, but the person-centered approaches we cover in this guidance can be applied to all other HIV services. To guide on implementing person-centered care, we will first provide an overview of how this guidance was developed and then provide a brief background on person-centered care, what it is, why do we need it, and what impact does it have. We will then give an overview of the theoretical principles of person-centered care based on several well-researched and tested frameworks. Then, we will provide examples and case studies to illustrate how these principles have been implemented and what has worked. We will further explore some of the challenges people have faced implementing person-centered care in different contexts and some of the opportunities that help put these principles into practice. We will summarize key messages and recommendations for different cadres of staff. And lastly, we have added a simple structured quiz to help you test your understanding of person-centered care principles from the evidence presented in this slide. At the end of the presentation, you will find resources and references for the work that contributed to this guidance. We encourage you to use the list of resources as a springboard to explore person-centered care for HIV treatment services further. Now let's look at the methods. This guidance is based on a review of different frameworks and the literature on person-centered care, including a systematic review conducted in low and middle-income countries on the types of person-centered care interventions implemented to improve client-provider interactions and the impact of these interventions among people living with HIV in these low-resource settings. It also incorporates consultations that the International AIDS Society has conducted over the past year to understand the concept and develop consensus around the approach. Lastly, it incorporates the experiences of those developing the guidelines. Note that this guidance focused on lower resource settings. There may be excellent examples of person-centered care from other contexts that have not been included, but could provide useful lessons. This guidance includes only published evidence shared directly with the team. Therefore, it may have missed interventions that have not been published or the wider perceptions and experiences of person-centered care.
Before we dive into the implementation, we're going to give you a little bit of background to person-centered care. First, we'll give you a definition. This concept has had many names in different contexts, such as patient-centered, client-centered, or people-centered care, personalized care or personalized public health, and relationship-centered care. Definitions are helpful to make sure that we're all talking about the same thing, so having a clear conceptual understanding of what we mean by person-centered care is the first step to understanding what the principles mean. A clear definition lays a good foundation that allows us to take these principles one step further and implement them in practice. Definitions are also important to frame the scope of what we're going to present in this guidance. A clear definition helps us clarify that we are focusing on the delivery of HIV treatment services and providing guidance for the healthcare workers delivering that care and the people organizing and supporting the services. The definition of person-centered care has been refined over time. In this guidance, by person-centered care, we are referring to care that is respectful of and responsive to the needs, experiences, values, and preferences of the individual as a unique and whole person. Person-centered care considers the complex health needs of a person beyond only their HIV. It also considers their identity and the context in which they live. It doesn't only focus on the disease. It is personalized, coordinated, and enabling. Person-centered care empowers people on treatment. It also focuses on the person receiving care, the person providing the care, and the relationship between them. And lastly, person-centered care treats people living with HIV as equal partners in planning, developing, and monitoring their care. Now that we're all on the same page about what person-centered care is, the next question is, why do we even need it? Firstly, as the HIV epidemic has evolved over the past 40 years, the priorities have shifted and changed. Early on, we were focused on delivering symptomatic care to clients with AIDS, but this has shifted to a focus on access to treatment as ARVs have become more widely available. The benefits of expanded access to treatment is that people are virally suppressed. This benefits individual people living with HIV who become healthier and have a better quality of life when they are suppressed. There are also public health benefits because people who are suppressed don't transmit HIV, reducing incidence and helping control the epidemic. As more people initiated treatment and we started to make headway towards the UNAIDS 95-95-95 targets, we've again shifted our focus to supporting engagement for a lifelong relationship with treatment to ensure that people sustain their viral suppression and that we can fully realize the benefits of antiretroviral therapy. We need to prioritize the evolution of our services to support this engagement with treatment. Person-centered care offers us an opportunity to implement an approach that puts engagement with care at the center and helps navigate the complex interactions between people who are accessing the services, the people who are delivering the care, and the health system responsible for both. The second reason that we need person-centered care is that people accessing HIV services are not a homogeneous group. They are all unique individuals who have complicated lives outside of their HIV diagnosis and treatment. Different factors interact over a lifetime of care to tip them towards or away from engaging with treatment. So they need services that can respond to the changing dynamics and the influences on their capability, opportunity, and motivation to engage with services. So one size most certainly does not fit all, and we need to adapt services from being centered around the system itself, where we prioritize efficiency and what we can easily deliver, to being centered around the people using the services and their needs. This aligns with differentiated service delivery models, which have people and their individual needs at the heart of their design. In addition to the focus on people living with HIV and accessing services, healthcare workers are also people within the system. Many healthcare providers are burnt out, and the challenges they face in delivering care often mean that they find themselves being quite unsupportive of people who are not perfectly engaged. This has a knock-on effect on clients' engagement. Therefore, we need to invest in healthcare worker well-being as well as client well-being. Putting healthcare providers at the center alongside the people accessing care makes a truly person-centered approach. Lastly, person-centered care doesn't just make practical sense. It is also fundamentally the right thing to do. Making sure that care is ethical and supports basic human rights is as important as improving our treatment outcomes. It is a good thing to do in itself, and not just a means to an end. So does person-centered care make a difference? The answer is yes. Person-centered care has emerged as a powerful catalyst for improved clinical outcomes. Firstly, it supports linkage to treatment, such as a study in Uganda and Kenya, where a person-centered intervention connected nearly 3/4 of people to care within a year, and nearly half within just 1 week of testing. It also improves engagement and suppression across different settings. In the United States, a client-centered HIV care model for people living with HIV and mental health conditions, improved retention from 60 to 68%, and it increased viral suppression from 79 to 90%. In Haiti, the Info Plus adherence intervention found that 31% of individuals in the intervention were adherent, much higher than the 17% observed in the control group. And in South Africa, the Welcome Service, developed as a person-centered intervention for people returning to care, demonstrated success in achieving 68% retention and 88% suppression by 4 months after restarting treatment. At a whole clinic level, the intervention clinics also had better retention and adherence during the COVID-19 pandemic. This shows that person-centered care can have a positive effect on the whole facility. This provides evidence that person-centered care can make substantial improvement in overall engagement and treatment success. And these statistics underscore not just incremental improvements, but rather a paradigm shift in our approach. Person-centered care has a pivotal role in achieving clinical success. Person-centered care improves outcomes, but does it improve the experience of care? In the implementation of the Welcome Service intervention, person-centered care was shown to enhance client experiences. People reported feeling welcomed and valued, with streamlined processes reducing waiting times and enhancing file management. The emphasis on client-centered counseling and addressing healthcare worker attitudes contributed to creating a supportive environment for people returning to care. It also improves quality of care. In a study looking at stakeholders' perceptions of person-centered care in Uganda, researchers interviewed clients in communities, healthcare workers, policymakers, and academics. They found that person-centered care positively influences people's views of the quality of services. Last but not least, person-centered care enhances the provider experience as well. A recent scoping review identified 8 studies supporting the association between person-centered care and job satisfaction. And in Zambia, when healthcare workers were introduced to person-centered care principles, it fostered a positive healthcare environment that prioritized client well-being and satisfaction, despite challenges like power dynamics and resource constraints. Person-centered principles shifted the provider's motivation and their approach to service delivery. This evidence underscores the importance of holistic approaches in healthcare interventions, where both the client experience and clinical outcomes are considered important. How does person-centered care fit into the changing landscape of global guidance? In July 2021, the updated recommendations from the WHO on service delivery for people living with HIV noted that health systems should invest in people-centered practices and communication, including ongoing training, mentoring, supportive supervision, and monitoring of healthcare workers, in order to improve the relationship between clients and providers. In July 2022, the WHO launched the Global Health Sector Strategies on HIV, viral hepatitis, and sexually transmitted infections. This guidance notes that putting people at the center of the health system response is the key to ending these epidemics. This means organizing services around people's needs rather than around diseases, and promoting integrated people-centered approaches and linkages with primary healthcare services. Also in July 2022, WHO released the Consolidated Guidelines on Person-Centered HIV Strategic Information, strengthening routine data for impact. These present a standard minimum data set, priority indicators, and recommendations to strengthen data use across HIV prevention, testing, and treatment. They also outline linkages to services for sexually transmitted infections, viral hepatitis, tuberculosis, and cervical cancer, integrating services as one of the principles of person-centered care. In 2023, WHO published the Implementation Guidance on integrating the prevention and control of non-communicable diseases into HIV, tuberculosis, and sexual and reproductive health programs. This guidance provides pragmatic, holistic solutions such as evidence-based checklists, practical considerations, case studies, and tools for various stakeholders to integrate care across diseases. Do global funders support person-centered care? Also yes. PEPFAR's reimagined strategic direction also highlights the priority to integrate vertical HIV and AIDS programs more efficiently and effectively into the local health service delivery infrastructure to manage services across multiple conditions that impact people living with HIV, such as tuberculosis, non-communicable diseases, and sexual reproductive health. The new Global Fund strategy also calls for resilient and sustainable systems for health that place people and communities, not diseases, at the center of the health system.
So how do we operationalize person-centered care? What are the operational principles needed to implement person-centered care? Many frameworks have tried to articulate the different dimensions of this important concept. Here, we present a framework that adapts the Health Foundation's definition and the person-centered framework developed by Shaw and others, and has further been informed by multiple rounds of stakeholder consultations led by the IAS. Starting from the top, person-centered care recognizes that a person seeking HIV care is a whole person, beyond their HIV diagnosis and the demands of the health system on their time and engagement. They are complex individuals who face multiple competing priorities between their health, work, hobbies, and family. Person-centered care considers their broader context and lives, including their biological, psychosocial, and community contexts, as represented by the violet color on top of the framework. Now heading around the framework in a clockwise direction. Person-centered care is also personalized. It recognizes that each person is unique and has specific health needs, but also preferences, values, feelings, beliefs, concerns, and expectations, as represented in orange. Person-centered care is respectful of this and is tailored to an individual's needs. It integrates care across the different services so that high-quality services are built around the person's needs rather than the health facility's needs, represented in dark gray on the diagram. Person-centered care asks healthcare providers to be empathetic towards people using the services and to support their dignity, represented in red. Person-centered care also focuses on both the person accessing care and the healthcare provider, putting the partnership between them as a central focus and making clients equal partners in planning, delivering, and monitoring their care, in color teal. All of these dimensions of person-centered care are interlinked, interdependent, and indivisible. Waweru and others found that people accessing ART care in Uganda understand the concepts of person-centered care and express a demand for it. People accessing ART services are in general asking for fairly straightforward improvements, that is good quality care and participation in the decisions about their health. Good quality care generally includes medications that are easily accessible, easy to take and don't make you sick, services that don't require frequent visits and are easy to access with short travel distances, short waiting times, flexible opening hours, free at point of service, and staff that are supportive of the people accessing their facilities. In fact, in one study by Zanolini and others, it was found that people were willing to trade off and wait 19 more hours or travel 45 kilometers further to see nice rather than rude healthcare providers. However, not everyone has the same preferences, and preferences change over time. People need care that addresses the needs they face at that point in their treatment journey and is responsive to their changing priorities. While some people still prefer to defer to their provider on all decisions about their health, Kumar and others found that nearly 3/4 of the participants they interviewed wanted to be involved in the decision-making about their antiretroviral care. Even if they see the healthcare provider as the expert who has the knowledge and skills to direct a good course of care, and the responsibility isn't an equal share between the provider and the client, people overwhelmingly want to be involved in decisions about their health and treatment. Making a decision requires a choice between options, which supports the introduction of different models of differentiated service delivery. So how do we start to put these principles into practice? The principles are universal and are important in every context. They are the characteristics of providers and services that are essential to implementing person-centered care. It includes seeing the person as a whole through the biopsychosocial view and prioritizing relationships between clients and providers. These principles form the foundation to design the activities and interventions that bring about change in the health system. They are at the center of operationalizing person-centered care. They are operationalized through the activities that are put in place to turn these concepts into care that is person-centered in reality. These activities fall under different categories. For example, activities that involve changing the structure or organization of the services themselves, or those that involve supporting healthcare providers to provide care that is person-centered. We will go through these in more detail in the next section of this guidance, but do bear in mind that how these activities are implemented has to be adapted for each context. In an ideal world, implementing these activities would result in converting the principles into person-centered care in practice. However, in reality, there are many obstacles and challenges along the way. These need to be mitigated in order for the activities to be effective. For example, established referral links and clinical processes might challenge the implementation of an activity to reorganize services to be more person-centered. So this challenge needs to be considered, otherwise the activity won't have the intended effect. There are also certain opportunities that can be leveraged to help facilitate the implementation of these principles. For example, increasing support from funders for integrating care across different diseases may offer support and help the team find funds to reorganize their HIV services to be more person-centered. In the next section of this guide, we will dive deeper into some examples of activities that have been implemented to operationalize the principles of person-centered care in different contexts. We will also explore some of the challenges and opportunities to implementing person-centered care in practice. Please do keep your context in mind as we go through examples of what other people have done. Think about how this would apply in your context, what challenges you may face, and what opportunities are there in your system to implement person-centered care. We will discuss how to operationalize person-centered care within 5 components that relate to the way health services are organized and delivered. These are 1. Service structure and organization, 2. Healthcare provider competencies and support, 3. Data collection, feedback, and utilization, 4. Client healthcare provider interactions, and lastly, governance and leadership commitment. We will explore 4 case studies with specific activities and examples under each of these components to demonstrate how specific factors have been effectively utilized to enhance the delivery of person-centered care. By examining examples of clustered activities applied under these broad categories, we aim to highlight the diversity of context-specific, actionable strategies implemented to foster person-centered care. As you will note from the examples, person-centered activities are non-linear and might involve multiple activities adapted according to the practice environment. Now let's look at some brief background context for the cases we will reference throughout the presentation. Case study A is a client-centered intervention called the Welcome Service Intervention implemented for people re-engaging in care at 2 primary health centers in Kailesure, South Africa. The intervention utilized a combination of practices to create a more welcoming and supportive healthcare environment. It focused on reorganizing triage, optimizing clinical management, enhancing counseling services, and addressing healthcare provider attitudes towards disengagement through healthcare provider training, capacity building, and information dissemination on managing disengaged clients. Case study B from Haiti was conducted in 2 ART clinics and involved developing and testing a provider-focused intervention using an electronic medical record-based alert to identify clients at future risk of ART treatment failure. Clients were then classified into color-coded categories according to the risk of assessment to direct more intensive counseling to clients in greatest need. Case study C is a step-wedge cluster randomized trial of an intervention intended to improve person-centeredness of HIV care across 24 government-run health facilities in Lusaka, Zambia. A step-wedge design is a plan that introduces a new thing or change in a gradual and systematic way. For the person-centered public health trial, the researchers introduced the study in a few intervention health facilities for 6 months and added more intervention facilities over time during the study timelines. The intervention included 3 main components. 1. Provider training and coaching. Secondly, collecting client experience data and sharing it with facility staff members, and supporting facilities to create improvement plans and providing gentle incentives for improved performance. Finally, case study D is a client-centered intervention that was embedded in a larger community-based cluster randomized trial in rural Kenya and Uganda. The goal was to accelerate linkage to care for individuals who tested positive for HIV. Firstly, these individuals were introduced to clinic staff to establish personal rapport between them and the staff. Further, participants were provided with a telephone hotline to call for any inquiries. They were also provided with an appointment reminder phone call, given transport reimbursement spent on linkage, and tracked if the linkage appointment was missed. We have provided references for these case studies in Annex 1 for additional information. Let us now delve into the specific micro person-centered activities in each of these categories.
We will start with service structure and organization to explore how to operationalize person-centered care using the 4 case studies described earlier. Services should be organized to facilitate person-centered care, which might require restructuring to center care around clients' and providers' needs. There is advocacy for integrated health services to improve client outcomes, enhance efficiency, and reduce costs. Efficient and integrated service models streamline healthcare experiences by being convenient for people. Differentiated service delivery models such as digitized services, telemedicine, community-led groups, targeted clinics provide opportunities for tailored and convenient services. In the next slide, we will explore these models. Digital tools have been optimized to improve client experiences with features like appointment and adherence reminders, convenient scheduling, inquiry hotlines, and easy access to health and lab records. Let's examine how structuring has enhanced patient-centered services in our case studies. In case study A, the Welcome Trust Intervention structured services for disengaged clients on their return visit. Mapping clients' flow informed the reorganization of antiretroviral services to reduce delays, streamline services, and prevent clients from being overlooked or turned away. In our case study B, the InfoPlus adherence interventions use technology, leveraging the electronic medical record system and an alert system to monitor vulnerable clients, showing the fusion of technology with client-centric practices. Implementing person-centered practices requires agility to address evolving client needs. Flexibility in service provision fosters empathy and person-centric mindset. Let's look at case studies C and D for insights into flexible work processes and resource distribution. In case study C, the person-centered public health for HIV treatment in Zambia trial demonstrated efforts to establish trust and foster a personalized approach. Examples include providers offering person phone contacts for follow-up consultations, facilitating referral services with a personal touch, and providing logistical support such as exempting extra fees or giving extra antiviral medicines. In case study D, the linkage to care intervention strategy in a community-based trial in Kenya and Uganda evaluated a multi-disease client-centered approach. This intervention included personal introductions between participants and clinic staff, a telephone hotline for support and appointment management, flexible clinical hours, transport reimbursement to support client engagement with treatment services. Service restructuring and organizations are crucial in advancing person-centered care by facilitating flexible adaptations to meet the unique needs of individuals and clients. Differentiated service delivery models, which we shall refer to as DSD models moving forward, structure services around the client and are rooted in person-centered care principles. DSD models for HIV treatment for clients who are established on ART can be categorized into 4 models. This can be group or individual-based models. Group-based approaches include those facilitated by health workers such as adherence clubs and community adherence clubs managed by people living with HIV. On the other hand, individual models can be either based at facilities such as private pharmacies and fast-track models, or in the community including home delivery, community pharmacies, community-based organizations, drop-in centers, and mobile outreach services. The introduction of monthly spacing has significantly enhanced the convenience and accessibility of these models. With DSD models, clinic consultations are separated from ART refills and psychosocial support, thereby empowering health workers and organizations to provide more effective care. Within the service structure and organization, there are both challenges and opportunities impacting the implementation of person-centered care. Among the challenges, in case study C from Zambia, healthcare providers identified several operational barriers that hindered the feasibility of person-centered care. These included limited infrastructure and resources such as laboratory capacity, counseling space, electricity backup, time constraints, and high client volumes. Motivating healthcare providers and maintaining their sustained efforts towards implementing person-centered care is crucial. Additionally, challenges in clinical and referral processes necessitate ongoing monitoring, particularly post-training. Collaboration with diverse partners adds complexity, demanding effective coordinations to ensure seamless integration and delivery of services. Despite these challenges, the landscape of HIV care presents significant opportunities for person-centered care within the service structure and organization. Funders are increasingly recognizing the value of integrated, holistic care that extends beyond traditional medical approaches. Integrating services across HIV, non-communicable diseases, and mental health addresses comprehensive individual needs and fosters a learning health system where evidence of impact drives improvements across all sectors. Digital innovations also open new possibilities, offering efficient and client-friendly services. This development indicates a transformative shift towards patient-centered care, reinforcing the commitment to providing personalized and effective care in the realm of HIV and beyond.
Healthcare providers are at the heart of the delivery of person-centered care. Service delivery is a complex interplay of rules, guidelines, and resources, but it is the healthcare providers that deliver care and bring together these different components in practice in a way that puts people at the center. Healthcare provider skills in delivering person-centered care affect client-provider interactions, provider-provider interactions, and care experiences. In the implementation of person-centered care, training and mentorship of healthcare providers is core. Training in person-centered care goes beyond the medical aspects of delivering HIV services. It must incorporate skills to shape a health environment that is not only medically effective, but also includes empathetic psychosocial support, understanding, and holistic approach to clients' well-being. Healthcare provider training and mentoring in person-centered care enhances application and reinforcement of the principles that fits with the spirit of the HIV response. We're going to explore some examples of activities implemented to enhance healthcare provider competencies and support for the delivery of person-centered care. In case study A, the Welcome Service Intervention, nurses and doctors receive training and mentorship to enhance their skills in assessing and managing disengagement and adherence counselors underwent training to manage complex psychosocial needs for re-engaging clients. All healthcare staff, from security guards to data clerks and clinicians, were trained to address negative attitudes that they may hold towards people who disengage from care. This training included 3 sessions that clarified their values and motivations as healthcare workers to reconnect them with their motivation to care for people with HIV. It explored the reasons why they as healthcare workers are unsupportive of people who disengage and why they might tip over into punitive behaviors towards them. And it created an understanding of the client journey and how choices to engage are influenced by so many factors that it is not always really a choice when people drop out of care. To integrate the welcoming approach into care, a welcome handshake was developed with staff and clients as an easy way to remember the 5 most important person-centered aspects of managing someone returning to services. Firstly, welcome the client back to care. Then, normalize the challenges that they face to demonstrate that they are not alone. Thirdly, acknowledge that they have made a big step towards engagement by returning to the facility and celebrate this. Then provide them with the support that they need to engage. And lastly, empower them to take ownership of their treatment and their care. In case study B, the Info Plus adherence intervention, the investigating team trained healthcare workers on how to explain treatment failure risk and how to motivate clients to change risk behaviors. A 2-day workshop was suitable for including doctors, nurses, pharmacists and pharmacy technicians, reception staff, and social workers, but community healthcare workers received training in a separate 1-day workshop. Additional on-the-job training was also required to catch up those who couldn't make the workshops, and monthly observations identified any retraining needs. Case Study C, the Person-Centered Public Health for HIV Treatment in Zambia trial, also included healthcare provider training for all health cadres, including leadership teams, professional, and lay healthcare providers. This was training on principles of person-centered care and to adapt the implementation approach to make the most of context-specific opportunities. The intervention provided continuous on-site mentorship and additional training by the study mentors who supported healthcare providers with delivering a culturally sensitive, context-appropriate, and flexible person-centered care implementation approach amid significant resource constraints. A helpful component was the brainstorming teams did to navigate the challenges they uncovered in training. Another helpful component of this training was unpacking what motivated healthcare providers. For example, some described seeing positive health outcomes from clients as highly motivating, while others described being motivated by teamwork among co-workers. These insights were used to motivate healthcare providers to deliver person-centered care activities. In terms of challenges, healthcare providers tend to prioritize physical health, potentially overlooking essential psychosocial aspects. Current medical education models emphasize disease-oriented approaches and could contribute to this gap by neglecting person-centered care. In Zambia, dedicated providers reported feeling undervalued, impacting morale and diminishing enthusiasm for person-centered care. Providing individualized care could be inconsistent due to systemic barriers and time constraints. In addition, healthcare providers face challenges related to power dynamics. Despite generally possessing a clear understanding of their roles, hierarchical structures can create disparities in who has the authority to make decisions, who has influence, and who has access to resources among different cadres. When such power imbalances exist, effective collaboration can become difficult. This affects communication and undermines person-centered care. While healthcare providers have knowledge about HIV treatment, staying updated on evolving guidelines poses challenges. Gaps in the proficient use of electronic medical record systems also affects how client information is used, making it more difficult to tailor care to individual needs and preferences. On the other hand, several opportunities exist that could support implementation of person-centered care. The accessibility of online training materials, coupled with the pervasive use of smartphones, has made the dissemination of comprehensive training and the provision of quality mentorship much more feasible than ever before. Harnessing the power of existing provider networks and dynamic professional development forums allows for sharing of invaluable insights and fosters a robust community of practice deeply rooted in the ethos of person-centered care. As the pivotal role of healthcare providers in championing person-centered care gains some well-deserved recognition, more resources are being allocated to nurturing and empowering them. The surge in funding not only elevates the proficiency of healthcare professionals, but also represents a commitment to delivering services that are inherently client-centric, reshaping the landscape of healthcare into one that prioritizes and celebrates holistic care.
The integration of data and data utilization to facilitate the implementation of person-centered care involves the systematic collection and analysis of data, incorporating both client and healthcare provider feedback and experiences. These findings provide valuable guidance in understanding client feedback, outcomes, healthcare provider experiences, and the dynamics of the practice environment for tailoring person-centered activities. Let us look at data and its utilization within the context of the case studies. In case study A, the welcome service intervention, the intervention team evaluated the implementation of the intervention and the clinical outcomes of study participants involved in this person-centered intervention. The activities conducted included program evaluations utilizing in-depth interviews with healthcare providers trained in the welcome service at the intervention site to explore their experiences of the intervention. The team also collected quantitative data from clients enrolled in the intervention to provide insights into the implementation process and describe clinical outcomes. Additionally, a pre- and post-evaluation was done to compare clinic-level outcomes before and after the intervention using anonymized, routinely collected health data from the Provincial Health Data Center. Case study B, the InfoPlus adherence intervention, was fully data-driven, using a prediction model that included baseline and time-varying predictors reflecting the consistency of ART medication pickups and other social, demographic, and clinical characteristics. The intervention also had qualitative measures of exit interviews with clients and focus group discussions with healthcare providers on the feasibility and acceptability of the intervention to build the evidence base for future person-centered work. Moving to case study C, the person-centered public health for HIV treatment in Zambia, which began with a formative phase in only 2 sites to inform the design of the intervention. During the pilot, the data was collected and insights gathered from clients and healthcare providers were used to tailor the curriculum training and mentorship content for healthcare providers and to shape the delivery of person-centered activities. Client experience data was shared with healthcare providers as feedback on their application of person-centered care. Client feedback mechanisms in the context of person-centered care are important for empowering clients with a platform to share their experiences and suggestions. For the full intervention in 24 health facilities, the study team measured various aspects, including service delivery, client experiences, client retention, client clinical outcomes, and provider experiences. These evaluations assessed the implementation effectiveness and the clinical outcomes of the study participants. The implementation of person-centered care faces challenges in the areas of data collection and quality improvement activities. Monitoring and measuring performance as well as capturing client experiences pose significant hurdles, creating difficulties in gauging the effectiveness of person-centered initiatives. Translating data into practical improvements becomes complex, highlighting a gap in interpreting and applying gathered information to enhance client care. The health information systems may lack feedback mechanisms, hindering communication between central governance and frontline providers. Additionally, a scarcity of data on the impact of person-centered interventions on HIV care outcomes limits the ability to assess the overall effectiveness of person-centered approaches in this context. Developing quality improvement plans tailored to diverse client needs presents another challenge, reflecting the complexity of aligning improvement strategies with the unique requirements of individual clients within a person-centered care framework. Addressing these challenges is crucial for optimizing the integration of person-centered care, ensuring data-driven enhancements, and fostering continuous quality improvement in healthcare delivery. The opportunities lay in the wake of healthcare advancements. and a wave of support for increased client and staff involvement in quality improvement programs, fostering a collaborative atmosphere for the co-creation of interventions. This paradigm shift is fortified by a burgeoning evidence base with success stories, which provide more examples of activities that can be adapted and implemented in different contexts. The evolution of cost-effective and user-friendly technologies further presents easier and cheaper ways of collecting data with better quality. New technologies also make utilizing and sharing it easier. Community-led monitoring approaches provide opportunity by integrating the community into the entire process of data collection and interpretation, which empowers people to take an active role in the quality of their care, ensures that the needs of clients and their community are front and foremost when setting objectives, the data collected is respectful and appropriate, and that the interpretation done is within the context. All these opportunities reinforce the centrality of collaborative efforts in shaping a healthcare landscape that prioritizes inclusivity, innovation, and ultimately improved client outcomes.
Person-centered care emphasizes active client engagement, empowerment, and shared power dynamics. It deviates from the norm of healthcare providers taking authoritative roles and dictating decisions to clients without room for dialogue or questioning. Let us look at some examples from case studies demonstrating how healthcare providers engage clients during interactions, offered space for them to identify solutions to challenges, and fostered their agency over their care. In case study A, as part of the welcome service intervention, the second clinic visit after re-engaging with care transitioned from merely creating a welcoming atmosphere to actively empowering clients to take ownership of their health. Using discussions, clients were encouraged to openly share their individual challenges and reasons for disengaging from care to help them identify what they needed to change and remain engaged. In case study B, focusing on the Info Plus adherence intervention, community health workers significantly leveraged the color-coded alerts derived from HIV viral load testing results. The original idea about alerts on the risk prediction for future treatment failure was that providers would be the only ones accessing and analyzing this data. However, community health workers took the initiative to adapt the plan. Using a motivational approach, they shared the alert color status directly with clients. Community health workers also displayed a job aid on the walls of the clinic waiting area and consultation rooms, which showed how to explain each color group to clients to inform and empower them regarding their adherence. These healthcare providers went beyond routine inquiries and actively engaged clients in reflecting on their experiences using prompts like, "Could you please share the good days when medication adherence felt achievable and the bad ones when challenges arose?" This deliberate approach encouraged clients to share their perspectives and experiences and engage them with problem-solving dialogue. In case study C, the person-centered public health for HIV treatment in Zambia trial, healthcare providers demonstrated commitment to active engagement of clients as care partners through open and transformative communication. They offered time and space to inform clients about their treatment and to listen to them, fostering client agency in taking active role in their treatment. For example, some providers explained complex medical concepts such as how antiretroviral therapy works and interpreted viral results using non-clinical terms in a local language understood well by clients. Moving beyond conventional clinical exchanges, healthcare providers showed power-sharing acts by actively inviting clients to participate in discussions and decisions about their treatment. The clients were not only engaged to feel free to ask questions, but were explicitly told that they had the right to inquire about their care. This inclusive approach extended to appointment scheduling, where providers sought clients' input on suitable or preferred day, emphasizing collaborations rather than dictation. Providers further fostered a sense of teamwork by expressing statements like, "Let us continue to help each other," and "Let us work together to manage your health." In case study D, after a person tested positive for HIV, they were introduced to a clinic staff. This was in person if they were tested at a health campaign or over the phone if they tested at home. This personal introduction firstly established personal rapport between the participant and clinic staff. It offered an opportunity to address any participant questions about HIV or the care provided in the clinic. The introduction ensured participants of person-centered, warm, friendly environment with flexible clinic hours and provided them with a telephone hotline. Providers need to consider how much they can do to provide person-centered care, taking into consideration the resources they have available and the client's preferences and needs. For example, in case study C, when clients negotiated additional care services and support beyond routine services, some healthcare providers used their discretion and offered their personal contact details for follow-up services. Now, looking at challenges and opportunities affecting person-centered care implementation within the client and provider interaction space, we see that the lack of a solid theoretical understanding of person-centered care poses difficulty for effective person-centered care implementation, as healthcare providers may struggle to grasp its underlying principles and nuances. Client or family involvement and tailored information about person-centered care may be challenging when clients or families have low literacy levels, hindering comprehension of the complex health information. Cultural differences, including variations in gender norms or significant gaps between healthcare providers and clients, can also strain communication. These differences may lead to misunderstandings and lack of trust, hindering person-centered care implementation. In addition, insufficient understanding of cultural nuances may impede successful implementation, with healthcare providers potentially overlooking critical factors. High client volumes limit personalized interactions, making it challenging for healthcare providers to engage fully in individualized care. Also, resistance from healthcare workers regarding concepts can pose a significant barrier to implementation. Traditional healthcare models often emphasize a more paternalistic approach where healthcare providers hold the authority and direct clients without regarding their preferences or opinions based on the belief that they know what is best for clients. So, introducing a shift towards person-centered care may be met with skepticism and reluctancy. On the other hand, enablers that could help support the development of more equal client-provider communication include expansion of community-led monitoring. Involving the community in data collection puts the client's preferences and needs at the forefront and means that we can identify what is working for them and what is not. The wide uptake and expansion of differentiated service delivery models is a game changer in healthcare. As people move to more person-centered models, they are empowered to engage with their care more easily. This not only benefits the clients, but also creates a more balanced workload for healthcare providers, allowing them to spend more time with those who need extra support than others. DSD therefore puts both the client and the provider at the center and is a win-win for all people in the system.
The health system itself functions either to enable or impede person-centered practices. Therefore, it is important to recognize the influence of the broader health system in implementing effective person-centered care, and not put the responsibility solely on healthcare providers. It is essential to recognize the link between client-centeredness and provider-centeredness. Implementation requires a nuanced understanding of the challenges that healthcare providers face and the efforts they invest, despite constraints, to implement person-centered activities. Governance and leadership commitment play a vital role in creating a supportive environment that acknowledges and appreciates the efforts of healthcare providers and makes them feel valued. This understanding is fundamental in fostering a culture of person-centered care that not only benefits clients, but also ensures the well-being and satisfaction of the dedicated healthcare providers who are at the core of service delivery. An example from case study C, the person-centered public health for HIV treatment in Zambia trial, underscores the impact of leadership in shaping client and provider experiences. Some of the lay and professional healthcare providers expressed feelings of being undervalued by management. The intervention addressed these concerns, providing training and continuous mentorship to management teams. The training and mentorship focused on encouraging a person-centered work culture and adopting a team-based approach to address existing power dynamics. Healthcare providers reported that they valued being heard, appreciated, and recognized by their supervisors and colleagues. This motivated them to provide person-centered care. Operationalization of person-centered care is faced with multiple challenges in governance and leadership commitment. Unified and sustained dedication is pivotal for successful integration, so one significant hurdle lies in the inconsistent commitment to person-centered principles from leadership. Entrenched structures may be resistant to aligning with the ethos of client-centered care, and this resistance hampers the cultural shift that is required for the widespread adoption of person-centered practices. Additionally, securing the essential resources and support for the effective implementation of person-centered care remains a persistent challenge. Adequate financial and human resources are crucial to facilitate training, infrastructure development, and ongoing support systems. The absence of such backing can impede the integration of person-centered principles into healthcare practices. But as always, there are opportunities in the health system. As the body of evidence supporting the impact of person-centered care continues to grow, a compelling case for its widespread implementation emerges. Person-centered care is not just a trend. It resonates deeply with the overarching policies of influential organizations, including the World Health Organization, setting the stage for a transformative shift in healthcare delivery. The ongoing and systematic review of organizational policies also provides a strategic opportunity to ensure that seamless integration of person-centered principles. By aligning with global directives and strategically embedding person-centered care within policy frameworks, organizations not only keep up with the evolving healthcare landscape, but also affirm their commitment to delivering care that is not just client-focused, but person-centered.
For next steps, think about the following. To synthesize the key messages of this practice guidance, the principles of person-centered care are simple and straightforward. They put people at the center, treat them with respect as whole people who have a life outside of their disease, and include them in decisions about their health. Appreciating the principles is one part of the bigger picture. Their implementation is another that requires adaptation to the local context. It's also crucial for healthcare providers to be driven to implement these principles, recognizing that this approach benefits not only clients but also healthcare providers can serve as a powerful motivator. When healthcare providers are supported, their relationships with clients improve and they receive better care. True person-centered care puts both clients and providers at the center of services. While changing the way the system works can help make it more centered around the people in it, many small daily actions can make care more person-centered. Person-centered care isn't a revolutionary intervention that changes the way the health system is run. We don't have to wait for funding or a directive from the Department of Health to implement person-centered care. Simple things such as creating a safe space for your clients to talk about their concerns, changing the language you use, or even just apologizing to a client when you're running late all contribute to making care a little more person-centered. Lots of little changes can add up to big changes that can make the health system a better place to work and receive care. It takes everyone, clinicians, counselors, data clerks, and facility management working together to realize person-centered care. How do you get started in applying person-centered care in your context? The first step in providing person-centered care is to understand the principles and get everyone in the facility on the same page. The next step is to work out what activities you implement to make the care you provide more person-centered. A key message is that context matters. We have given a range of examples of how others have implemented the principles of person-centered care and explored what worked for them and possible challenges, but they are just examples and are not prescriptive. While the core function of person-centered care is the same wherever you go, the exact form it takes depends so much on your context, the challenges you face, and the opportunities you have. Our recommendation for your next steps is to think through the following questions. How do the principles of person-centered care apply in your context? What is already being implemented? Where are the gaps? Which of the activity examples make sense to implement in your facility? What can be implemented as is? What should be adapted? What challenges do you face in making person-centered care a part of your everyday practice? How can you overcome them? Whose support do you need? Are there any opportunities you could leverage to bring more person-centered care to your services? What does your team already do well? What are their priorities? What are the Department of Health's targets or priorities? Are there any non-governmental organizations or other organizations that could offer training? The power is in our hands. We do not have to wait for someone to help us. Together, we can do it.
Many thanks to Andrew Marvin Kanike, Chanda Mwamba, Claire Keane, and the review team for the work on this helpful resource. Quick quiz to consolidate your learning. 1. What best describes person-centered care in the context of HIV treatment services? A. A treatment approach focused mainly on antiretroviral adherence. B. A care model emphasizing the individual's unique healthcare needs, identity, and respect. C. A standardized protocol for HIV treatment applicable to all healthcare clients. D. A care strategy focusing primarily on the physical aspects of HIV. E. A healthcare system that prioritizes client needs over healthcare worker convenience. The correct answer is B. Person-centered care in the context of HIV treatment services is best described as a care model emphasizing the individual's unique healthcare needs, identity, and respect. Which of the following is a principle of person-centered care? A. Prioritizing healthcare provider decisions over client preferences. B. Providing care that is empathetic and respectful, acknowledging each client's uniqueness and the entirety of their needs. C. Limiting client participation in decision-making regarding their care. D. Focusing exclusively on the clinical aspects of HIV treatment. E. Implementing a one-size-fits-all approach to client care. The correct answer is B. A principle of person-centered care is providing care that is empathetic and respectful, acknowledging each client's uniqueness and the entirety of their needs. Question 3. Which of the following is a key reason for the need of person-centered care in HIV treatment? A. Clients prefer a strictly clinical approach to their treatment. B. There is no significant evidence suggesting person-centered care impacts clinical outcomes in HIV treatment. C. Clients desire quality care that responds to their needs, including shared decision-making. D. Person-centered care has no advantage over traditional care models. E. Clients prefer and only trust decisions taken by healthcare workers for their care. The answer is 3. Clients desire quality care that responds to their needs, including shared decision-making. 4. What represents an opportunity to effectively operationalize person-centered care in HIV treatment services? A. The expansion of community-led monitoring approaches where clients themselves monitor the quality of healthcare services and identify areas for improvement. B. Recognition of the importance of healthcare worker well-being and their central role in person-centered care. C. Leveraging the growing availability and implementation of innovative digital tools to integrate care across different conditions. D. Demand to integrate services across chronic conditions, including HIV. E. All of the above. The correct answer is E. All of the above. This brings us to the end of this presentation. If you want to learn more, register for our free online course, Differentiated Service Delivery for HIV Treatment, now available on IAS+.